Hello everyone, welcome to MedZone Lectures, and in this lecture we are going to be talking about antihypertensives, and then we will add some mnemonics to help you to remember them quickly. My name is Emmanuel Arthur Nyamije. When we talk about antihypertensives, what we are trying to talk about is the drugs or the medications that we provide when somebody is having hypertension, or what we call high blood pressure. So looking at the antihypertensives, here are a few of them. We have the beta blockers, and in the beta blockers we say olol because they all end in olol. So this dash here means something and the ending is olol. So all the beta blockers have olol at the end. That's beta blockers. We have the ACE inhibitors, and with the ACE inhibitors we have something in front and pril at the end. So all the ACE inhibitors have pril at the end. When we come to calcium channel blockers, we have the dipens and the cardioselective ones. I mean dipens and the cardioselective ones because the cardioselective ones doesn't have dipens at the end or dipens at the end. So we have those that have dipens at the end and those that are cardioselective. Cardioselective in the sense that they specifically for the heart. So we'll talk about that in just a moment. We have the alpha 1 blockers, alpha 1 receptor blockers, and they end in osen. So something comes in front and then osen. We will talk about it in just a moment. We have the angiotensin 2 receptor blockers. They block the angiotensin 2 receptors. So we have the something in front and the satans at the end. So they end in satans. You have the renin inhibitors. They inhibit renin. That is to say, they inhibit the RAAS system, which we'll talk about in just a moment. We have the directives, and you know the directives, we have the loop directives, the potassium sparing directives, and then the thiazide directives, which we'll talk about them in a moment. So these are actually the antihypertensives that we are going to be talking about today. Let's go straight to business. So looking at beta blockers, we said they end in olol, something in front and olol. So let's talk about the beta receptors and their locations. We know we have three beta receptors. We have the beta 1 receptors, beta 2 receptors, and beta 3 receptors under physiological conditions. Now, beta 1 receptors are found in the heart. And actually, what they do is they increase the rate, the force, and automaticity of the heart. And then the beta 2 receptors are found in the smooth muscles. You know, smooth muscles can be found in the organs and also can be found in the blood vessels as well. And beta 2 receptors, when stimulated, causes relaxation of the smooth muscles. Now, when we talk about beta 3 receptors, they are found in the adipose tissues, that is the fat tissues, and they increase lipolysis, the breakdown of fats. Let's look at how beta blockers are going to impact over here. Now, beta blockers, also known as beta adrenergic receptor antagonists, have three types or three generations. We have the first generation, which is non-selective, that is to say it can act on any of these receptors. So if you take the first generation beta blockers, they can act on beta 1 receptors and inhibit them. They can act on beta 2 receptors and inhibit them. They can act on beta 3 receptors and inhibit them. That is to say, they will cause the opposite of what is happening over here, here, and here. And that is where side effects come in. For example, if you take nadolol and a patient is having an increased heart rate, and you treat the patient with nadolol, because nadolol is a first generation non-selective beta blocker, of course it is going to do its work. It's gonna counter effect the increase in the heart rate, but then the side effect is gonna come from the blockage of the relaxation of the smooth muscles. So the smooth muscles are going to contract, and then the adipose tissues are not going to have lipolysis anymore. They're going to have lipogenesis. You get it? So that is the side effect that is going to happen for non-selective beta blockers. They have huge side effects. Now, if you look at second generation beta 1 selective blockers, since it is beta 1 selective, they act mainly on beta 1 receptors. Therefore, they inhibit the activity of beta 1 receptors. That is to say, they inhibit heart rate by reducing it, they inhibit the force by reducing it, and the automaticity, they reduce it as well. They do the opposite of what beta 1 receptors will do. They cause inhibition, and that is beta 1 selective blockers. Now, the third generation is vasodilatory, and we have two types. We have the non-selective and the selective beta 1. Now, looking at the non-selective ones, we have the labetalol, carvedilol, among others. And these non-selective, as we said over here in the first generation non-selective, they are also non-selective among all the beta receptors. So they can act on any of these and cause a side effect. But the beta 1 selective for the third generation is going to cause vasodilatory action. Instead of causing contraction, it's going to cause vasodilation because it's going to act on beta 1 receptor only. And then we know that these beta blockers have additional alpha blocking activity, which we must not ignore that.